Everyone, my name is Shangzhen Chen and my advisor is Dr. Chen from China Medical University. Today we are going to talk about therapeutic effects of exercise combined low-level laser therapy on patients with peripheral artery disease plus diabetic foot ulcer, and this is a pilot study on feasibility and therapeutic effects. Diabetic foot ulcer is one of the most serious complications of diabetes. It will lead to some level of lower extremity amputation, and the risk of death is higher when the patient has foot ulcer or become amputated. Peripheral artery disease is an independent risk factor for foot ulcer, infection, and amputation. Peripheral artery disease prefers PAD. The severity is ranged from asymptomatic to critical limb ischemia. Patients with PAD experience a decline in functional capacity and reduced quality of life. According to Plumper, about 50% of the patients with diabetic foot ulcer also have peripheral artery disease because diabetes is associated with osteogenesis. And microcirculatory dysfunction is characteristic of diabetes. It reduces capillary blood flow, reduces hyperemic response, and vasodilation, especially in patients with PAD and diabetes. PAD also impairs downstream cutaneous microvascular vasodilation function. Combination of PAD and diabetes resulted in more difficult wound healing and poor outcome. The relative contribution of atherosclerosis and microvascular dysfunction is very difficult to determine. So, even after successful revascularization, cutaneous microcirculation still cannot be recovered completed, and about 40% of the wounds are still not healing in 1 year follow-up. So the patient with PAD and diabetes, we call that diabetic PAD, represent a special subgroup. They tend to have different clinical presentation, natural history, and outcomes. Low-level laser therapy is beneficial as an adjunct to conventional therapy in accelerating the healing of diabetic foot ulcer. It not only decreased inflammation, increased granulation, but also increased angiogenesis and improved skin microcirculation. In the previous study, peripheral artery disease was excluded, so there is no study investigates the effect of low-level laser for patients with diabetic PAD. And the diabetic PAD patient have less walking distance, lower physical activity level, and reduced physical function. No matter patient with diabetes or have peripheral artery disease, there was a faster decline of muscle mass and muscular strength, but also, according to American Diabetes Association, the weight-bearing activity should be avoided with unhealed ulcer. So the resistant exercise is an effective strategy to counteract the deterioration of muscular performance and working ability in patients with diabetes or peripheral artery disease. So the purpose of our study is to examine the therapeutic effects of exercise combined low-level laser therapy on patients with peripheral artery disease plus diabetic foot ulcer, whether it can improve microcirculation and wound healing, and improve and maintain working ability to delay muscle atrophy. And here is our study design. After assess the eligibility, we randomize the participants into control group and low-level laser group. We use stratified randomization based on wound size and ambulation status. The treating frequency is 2 to 5 times for each week and totally for 4 weeks. The control group received conventional treatment and exercise. The low-level laser therapy is conventional treatment, exercise, and low-level laser therapy. And the pre, mid, post intervention evaluation is at baseline T0, week 2 T1, and week 4 T2. The inclusion criteria is the patient have to diagnosis as type 2 diabetes and PAD. The ulcer was located on the lower extremity and present for a minimum of 2 weeks. The exclusion criteria is that the patient have acute cellulitis, osteomyelitis, and hepatic hematologic immune disease, presence of malignant disease not remission for more than 5 years, and they use corticosteroid immunosuppressive agent, and pregnancy. The level radiation is for 10 minutes, which equals 4.5 joules per centimeter squares. And our exercise intervention consisted of resistance exercise and functional activity training. The resistance extends the major target muscle is hip extensor, hip abductor, knee extensor, and biceps and the triceps, and the functional activity training is individualized. The outcome measure includes the wound size measurement by image size software, and we classified the wound by Wagner classification. The microcirculation is used skin temperature by thermography of the dorsal and the plantar side of the foot. The pain intensity of the wound is used VAS to assess, and the sensory was assessed by Sam Weinstein monofilament. If the patient was unable to perceive more than 4 points of the 10 sites, was regarded as abnormal sensation. The walking ability was assessed by 6-minute walk test, and the quality of life is assessed by SF36 scoring system. The protocol had been approved by ethics committees of Fengyue Hospital, and we use non-parametric analysis. The comparison between the groups was used the Mann-Whitney test, and the intergroup comparison was used Fredman test and Wilcoxon test. Category data was analyzed by chi-square test. Here's the result. After we assessed 25 participants for the eligibility in 1 year, 13 were excluded. Mostly was because they refused to attend the protocol. Finally, we got 5 in each group was included in the primary analysis. Here is the baseline data. There was no significant difference in the characteristic data. And here is the outcome measure comparison within group, and we found that the wound size and the percentage of wound reduction was significantly improved in the low-level laser group, but not in the control group. Also, the 6-minute walk distance was significantly improved in the low-level laser group. The control group, although they improved, but not significant. When we compare the score of SF36, we found that bodily pain was improved significantly in the low-level laser group, but not in the control group. And we see the comparison between groups. We found there were no significant difference in any of the outcome measure, neither in the score of SF36. And here is the comparison of Sanford's test. We found that besides the unaffected light was improved, although not significant difference, but the normal rate of the control group improved from 33% to 66%, and the normal rate of the low-level laser group was improved from 66% to 100%. We also calculated the correlation of the percentage of wound reduction and the skin temperature. We found there was a strong positive correlation between the mean value of T1 and T2 of skin temperature of the plantar side with the percentage of wound reduction, which means the higher temperature was correlated with better wound healing. Discussion. This is the first study of the therapeutic effects of exercise combined with low-level laser on patients with PAD and diabetic foot ulcer. The low-level laser can increase angiogenesis by modulating cytokines and improve skin microcirculation. And according to a previous study, we found that low-level laser can work in ischemia situation. The diabetic mice with hind limb ischemia treated with low-level laser had doubled the capillary density and blood perfusion, and even in the occlusion of regional blood vessels, low-level laser can accelerate collateral circulation and enhance microcirculation. And only few studies have focused on the effect of exercise on patients with diabetic PAD. And according to Allen, after 3 months supervised exercise training, diabetic PAD improved the maximum work time in exercise testing, but improvement of the claudication onset time was attenuated. We found that the diabetic PAD patients have lower physical activity and reduced physical function. So what happened if they experience a period of bedridden? Our participants all experience a period of bedridden, and mostly from the instruction of the physician due to the bypass surgery. Exercise training at the right time was also the reason that the participants improved their walking ability. If without the exercise training, these patients might decline faster in muscle strength and physical function, and leading to irreversible physical disability. Although the evidence for exercise can facilitate diabetic foot ulcer healing was not enough, especially for patients with concomitant PAD. According to previous study, we found that the endothelial function was lower in patients with PAD and diabetic PAD, and exercise can improve the endothelial function. And according to Lima, we found that combined resistance exercise and walking exercise can increase plasma nitrate and decrease leg vascular resistance, but further studies should be investigated. Here is the conclusion. Exercise combined with low-level lesson might enhance wound healing and reduce pain in patients with PAD and diabetic foot ulcer. Also, the exercise was able to maintain and improve the walking ability of patients with diabetic PAD. And here is our reference. And thanks for your listening.